category now.
Why would that be though?
Like you instilled a lot of knowledge that I can't forget in a hurry. And I don't even want to forget them because I know that that is what I need. Moving forward to be the best I can. In this career. And I really want to appreciate you for that time. When I started, like I told you, I didn't just start, like registering. I saw you on YouTube, like you popped up on YouTube, and I started listening to your classes, your brief questions and answers, and I got hooked up. I had other referrals who join this one, do the other one, but at some point I told them that my heart is somewhere. For some reason, I just got hooked up to these men's classes, that I, I have to do the needful, do it the right way, like register and all of that I believe is going to pay off. Some people are like, okay, if you do it, if you don't pass the first time, then you can go with the other people. I say, well, I don't believe I'll fail because this man is really doing the real, like he's teaching,
Hmm.
and I want to appreciate you because trust me, going through questions, I could just like in the middle of reading the question, my brain is already telling me that this is the answer.
So you
Before
pass. You
I
pass the board.
passed, I
All
passed the
right.
board.
All
I
right.
passed it.
You
Yeah.
know, I have done this over 3,000 times, and every single
No.
time I
No.
get goosebump when I get those results because I know in my heart, and
Mhm.
3,000 people have done the same thing. If everyone follows the program, there is almost no chance that you would not pass because you are
Yeah.
learning, you're not memorizing. And this will
Yes.
absolutely help you forward, not just now, you know.
Moving
But it
forward.
is a longer path. I recognize that I ask a lot. I ask for question banks, diagnostic tests, crash course review, full review. But at the end, the results will be sweet. Those that are
Yes.
try to do shortcuts, they may or may not pass, you know.
Mm-hmm. Mm-hmm.
So, well, congratulations. Thank you so much
Thank
for stopping by today.
Thank you very much. I'm definitely signing up for the therapy.
Pharmacology. Yeah.
Yeah,
So
pharmacology.
I
Yeah.
have to give a warning, right? Because my goal is not really is not to make money, because otherwise I would kick everybody off after one meeting, right? My goal is
Mm-hmm.
really to empower you. That class, it is 1 year of psychopharmacology course, and it's not easy, right?
Okay. Okay.
Sorry. I guarantee you that the knowledge that you will receive in that class, it is unmatched. There is nothing out there. Now,
Sure.
it's not a quick fix. It's not like, oh, just do 1 week. I'm putting you, if you follow the program, I put you in the top 5% of all PMHNPs with no, no concerns. Now,
Mm-hmm.
I'm going to break it down each medication by receptors, by things that you need to know. So it's not a quick fix. It needs dedication, but those that finish that course, they can talk to a psychiatrist any day of the week and know everything about medications. I guarantee you that.
Okay.
It takes dedication. I gotta warn you because I'm not looking for a sale. I'm
Okay.
looking for preparing folks to take care of real patients. That's what I'm looking for.
Okay. Thank you very
Okay.
much. Thank you. I
Well,
really appreciate it.
congratulations on passing the
Yeah,
board.
just want to
So,
encourage everybody, stay put with Dr. Lopez. Stay put. You won't regret it.
yep. All right. Good to see you.
Thank you.
Thanks for
Yeah, bye
stopping
bye.
by.
Yeah, bye.
All right, folks and everyone. Good morning. Maybe today is the first time that we met. Maybe we've been online with you for a while. Regardless, this is a very, very important day. 2 days, right? Many people say, "Oh, you could do this in 5 hours." Yes, but the results would not be the same. Maybe because we are joining, doing things a little bit longer with more care, the results it is much greater is a positive results compared to others. Okay. Now I uploaded the documents and I did a little bit of reviewing this week. So please go to your XP or your learning platform. And if you see this right here, right, you go to any modules and you see this right here, all trainings, click on all trainings. Okay. Click on all trainings and then you will see, I'm just going to wait a minute here to allow everyone to catch up.
Good morning, Dr. Lopez.
Good morning.
I passed my ANP on Wednesday.
All right, all right. Good job. Wow, that is also so exciting. Did you do AMP or ANC
I did ANP. I'm doing my ANC next month.
next month? Okay, Lola, kindly send me an email. You have to do that, please. Because you know it's not a we say it's up to 6 months for everyone, but when folks pass it, there is a very high cost to keep everyone in updating, and I do not want to delete your account. Just say, hey, Dr. Lopez, I passed the AAMP, I'm doing my ANC, keep my account active, so that way there is no mistakes, there is no, we want you to pass both if you if that is your wish. Okay. But how was the test? Did you find it the content that we taught helpful even for the AAMP?
I mean, I feel like because the exam structure, if you remember, I did
MC?
NC first, and I missed by the 3 questions.
Right.
So, which I kind of understood what happened then. I think if I had prepared a little bit, given myself like maybe 2 more weeks to just absorb the content, especially the PDF, that would have made a difference. So with that, I decided, okay, let me register for the ANP and see, so in between the 2-month window, I'll be able to prepare and do the ANP, which I did. I found their content very helpful. Like ANP, you have to know the content. The the other one, I mean, I'm mixing
ANC.
ANC, that one, your questions are very similar, very structured in the same way. But when I got to ANP, it was so different. One, the questions are just like one line, but it's more like content based. You have to know the content. So it wasn't so much of the story. I think very few questions had like maybe up to 3 lines, but it's strong on content, scientific piece. I didn't see much of the therapy, even though I know I'd emailed you and you said, okay, well, focus on module 1, 2, 3, and 4. Therapy was also in there, but I don't, maybe, sometimes when you're writing exams, you're so much into the moment. But I saw a few, especially the theoretical theory was heavy, and they were heavy with adolescent stuff. So not so much of like, most of the questions were related to adolescents, but the content also helped because when you're talking adolescents, you're talking adult, it's kind of intertwined. So you need to know, and they had a lot of medication. They had so much. I didn't see dopamine pathway so much, but there were a lot of questions related to lithium, carbamazepine. So it was so like content based. I mean, I finished before time this time, unlike the first exam that I took where I was scrambling for time. So this time I make sure I, did your content and did module 1, diagnostic with time in mind. That really, really helped. So when I knew I was hitting like the 85-ish, like you said, I knew I was somewhat ready.
You're ready.
I would just encourage everyone, just use your PDFs. Use your PDFs, please. Highlight things. Well, I mean, like when I started, seeing some of the things in my sleep, I knew I was ready. And like people said, they will hear the voice.
yes. You do, because at that point, it's like like a language. I speak 5 different languages, and so, and if I start dreaming in French, I know that I already got the content. I know that I can already speak and communicate well. It is similar in that regards. So what is similar here? So your hippocampus is converting your short-term memory to long-term memories that at times it translates into dreams. This is something behind the scenes that happen, but the more you do, the better you get. It is important not to rush the process. People want to just pass the board, and I get it and totally want that. But the process is important because it will serve you well, not for only passing the board, but to take care of patients, which ultimately it is the goal. So, well, congratulations. I appreciate it. I know you will pass the other board as well. So you already passed one. So now you are free spirit that you can just walk in there, kick the door, and don't have to worry too much about it. And that is the beautiful thing about doing two boards,
Absolutely.
because you don't have to be, oh my God, oh my God. Guys, I promise you, today's event will be fantastic. It will be nothing short by fantastic. In the next 10 to 14 days, 2 weeks, I will receive almost 10 emails a day saying, hey, Dr. Lopez, I passed. Hey, Dr. Lopez, thank you. I mean, today alone, I was a little bit late logging in because I was answering emails. Many of you guys in the next 2 weeks will be board certified. So
You're muted, Dr. Lopez. We can't hear you.
thank you, thank you, thank you. If that happens, please let me know because I will be muting everybody. But for some reason, this is happening quite often. The next 2 weeks, many of you guys will be board certified. Okay, so many of you guys, maybe 10 a day, every single day. That is the goal. Everyone, I'm just waiting a minute to give instructions while everyone else is coming in. Prissy, do you have a question there quickly?
Yes, a quick question, Dr. Lopez. Good morning.
Good morning.
This crash course that we're doing, is this one recorded?
It will
And
be recorded. It takes about 72 hours or 3 days for me to get the recordings, for me to upload everything. It is a big job that the technical team has to do it. Every other crash course review that has been done will be deleted. Okay, so if you
oh,
are using the old ones, please, 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 uh, kind of let me know. I guess you can send me an email. But here's the deal, guys. If every time I do a live class, I upload it, I will have 100 videos. Will 100 videos be helpful to you? No, right? So we have to put in, give you what is helpful. So we are going to delete the old crash course reviews and only upload today's and tomorrow's event. So that way, it is 2 days. It is a minimum 16 hours or so, anywhere around there. So you don't need the 100 hours of videos, okay?
mhm,
So I think
okay.
most of it, did I answer your question, Prissy?
Yeah, so then each new crash course will override the old one.
More so because they are almost all just very similar. But today it is different than all other ones. I kind of
Okay.
did a lot of new questions, a lot of new prompts. So today is very different than the previous one. Um, but overall, the content is the same. There is not
Okay.
much of a change. Okay.
Okay. And just one last thing. Today's crash course, will it be the same as tomorrow's, or tomorrow's will be different?
Totally different tomorrow.
Okay. Okay. Thank you.
But we will repeat a lot of things from today. But tomorrow, instead of me teaching or showing you a paragraph, I'll ask you short questions. For example, one slide will say, what happens if lithium is taken with NSAIDs? And then I'll click next and they'll show lithium toxicity. Do not mix lithium with NSAIDs. So that I'm trying to hit you with the same stuff in different angles. Because some people are more visual, some people are more verbal, written content. So I'm hitting you with many different directions. And I do recognize that can cause some stress. But please understand that passing the board is not easy, but you will pass the board. You will pass the board, and the end result will be sweet. It will not be disappointed. Okay, you will not be disappointed. As long as you are doing what you have to do from your end, you will absolutely pass the board. Okay, we do one more question because then we got to get going here. Christine, quickly, kindly, please ask a question. You have to unmute yourself.
Yes, good morning, everyone.
Good
So, Dr.
morning.
Lopez, the crash course that we're doing today, that's going to cover what modules? You're going from module one?
Negative.
Oh,
So it is the crash course review, right?
oh, the reason I'm
So
asking because I see you have something from module one up. That's why.
uh, it's okay. Oh, I'm so sorry. Here. No, no. The
Yeah.
goal for
Okay.
this, thank you, thank you. The goal for this is to say, I'm waiting for everyone to log in.
Okay.
All trainings here. I
Mm-hmm.
want you guys to go to all trainings, log in,
Mm-hmm.
so that
Mm-hmm.
way I can show you where the PDF for today's content is. Okay?
Okay.
So
All
let's
right.
do
Yeah.
that right now. If we go to all trainings, again,
Uh-huh.
before we go there, all the PDFs are located in the same place. So where is the location of the PDF? Under the first video of each module.
Morning.
Good morning. So
Morning.
under all videos of the first module, for example, well, that's a good example here. The first video of module one, it is the cerebrum. What is under the cerebrum? The PDF right here. Okay. The basis for your AANC, really, even AANP, is to know PDFs 1, 2, and 3. That is modules 1, 2, and 3 so well that is makes it impossible for you to fail the board. Well, let's see that. There will be 107 questions from modules 1, 2, and 3. If you know modules 1, 2, and 3 really well, meaning you get 100 questions out of 107, that is knowing really well, you could statistically close your eyes and pick any other answer and still pass the board. I challenge anyone that has not passed the board to show me their score where they said, hi, 1, 2, and 3. It has never happened. Usually people don't pass the board because when they see the reports, I see module 1, high, everything else low, right? So that means that if you really put all your efforts on modules 1, 2, and 3, the rest, I'm not neglecting the rest, but the rest is less questions. We have to put our effort where most questions come from. So again, PDFs are located under the first module of the first video of each module. So let's go to today's event PDF. So we can go this by going to all trainings right here on the screen. And then you select the module that you want to go to. Today's event is the crash course review. So you click crash course review. And then you pick the first module of the crash course review right here. Guys, all these videos will be deleted once the new videos are uploaded. Okay, so that way you have the newest content. That will take 72 hours. So again, if you go to the first video of module 6, what you will find is all the PDFs for the course. Guess what? I kind of worked really, really, really hard for the last 2-3 weeks, extra hard, to kind of clean up some of our PDFs so you have less friction and more high yield content. So I broke it down into day 1, which is today's event. All you have to do now is download it and keep it. Tomorrow will be day 2. However, I'll be presenting in a PowerPoint and you have the same version in PDF. They will be similar, but not the same at all. And then before you are going to test, take a look on Crash Course Review Highlighted, which is a version of day 2, but I went ahead and highlighted even more so what's more important out of day 2. Okay? So basically, I'm hitting you with all different directions within the same information in different ways. Now, I leave here just the strategies. I do not think you need to download this today, but this is where we'll begin. It's just about strategies. Okay? So a few things to keep in mind. I do not think you need to download it, but if you want to, it's right here. What is important for today? Day 1. So right now is your time to go ahead and print it if you want to, or don't print it yet. Just follow along, writing down. Okay? And then later, print it and compare your notes. Why is it important for you to write it down? Because when you do, you activating your parietal lobe, right? Reading, writing, it's parietal lobe. Clock drawing test is the parietal lobe. So that is the number one thing for today's that you need to know. The clock drawing task is the parietal lobe, right? As you write things down, you will put information in your brain. So it's very important because today is a long day, tomorrow is a long day, and we need to be focused. So write down stuff, it will help you. Okay. But if you want to download this today, you can, it's right here. Okay, so let me download my version of this. All I have to do is click it, and I am ready to go. Then it shows up in my computer here on the top, and then save it. Okay. Now we'll start with this right here, which is the strategies, right? So I'll give you some strategies as we go through. So give me a second to get the document. Remember, strategy is good. However, it's not what we do, right? We don't base our future on strategies. Strategies are something that we like to know, but it's not our go-to resources. Okay, so it's not what we do permanently. It's something that is important, but absolutely not our what we rely on. We rely on knowledge and understanding of the content, and that is what will absolutely save your career. That is absolutely what will help you on any board. I challenge you, if you do the program, I don't even care what board you take, you will pass. I promise you that. It is very difficult to make that promise. But what happened is when somebody says, I didn't pass, I go through everything that they did and I find bunch of holes all over the place. They didn't do the question bank. They didn't study. They just went through the modules while washing the dishes, right? It is important. This is why we have an app. I don't even like to tell you that we have an app because I believe studying is a sacred time. It's the time that you pretty much, at least when I study, when I am learning something new, it's almost like I'm freeing myself and I close the door. I make sure I have silent in a house. I make sure I am in tune with what I'm learning so that way I can keep it and use it, right? Okay, so I do apologize. I know we have some questions, but again, I think Christine just had her question. C and Mary, I unfortunately I cannot answer your question. Oh, Iboni, she just passed the board again. Well, congratulations, Iboni. So I thank you so much for letting us know that you passed the board. That is awesome. So that's 3 folks that came in today and said, hey, I passed the board. So that is another one. I know, Iboni, you've been here with us for a little while, so I am very happy to see that you passed the board. So thank you so much. Please send us an email. I just want to kind of send you the psychopharmacology course. Yes, everything, the course is everything. So that's what she said here. Congratulations, Iboni. Um, guys, I challenge you. I really challenge you to do the work. I highly doubt that you will not pass. It's almost impossible to not pass. Now, when that happens, it could be because they didn't do the work, right? Or they did the work
Life
and
period.
then took
Out of all the
3 weeks
life,
off or so forth, right?
zero.
So it is important that you do the work with intensity and go test it, right? So the recommended time, at least in my eyes, there is no good recommendations, right? But I have seen people with 3 weeks doing everything very fast and passing. Now, I think that is rushing, right? I think 3 weeks is for those that don't necessarily have kids, have a job, even though I know somebody that just have 2 jobs and kids and a husband, very busy, and she passed in 3 weeks. That is fantastic, and but that is not normal either, right? If you have a busy life, it is hard. I get it. Okay. But I challenge you, if you are involved, if you are doing the question bank, if you are doing the diagnostic test, if you are continuously reviewing PDFs 1, 2, and 3, that is for the 30 days PMHNP Walk to Success, and you attend the crash course review, I challenge you, that is almost impossible not to pass. Okay? That is the great news. Now, the sad news is just join the program. It does not guarantee you a pass. Just like going to the gym. If you join the membership, it does not guarantee you muscles. You have to do the work. Okay. I'm not selling you anything. I do not want you to, when people say, if I join the program, will I pass? I say, if you do the work, you will pass. Okay. The program is a tool, and I am your coach to help you pass. But ultimately, it's impossible. I cannot, even if I could, I probably would force people to study, but it's up to you to do the work. And that is, but the good thing is if you do, it's impossible not to pass. It's almost impossible. Okay. So that being said, so I do apologize. We have some people with questions, but what we'll do is after the crash course strategies, we have numbers. I put in numbers so that way you can remember the number of your question. Once the crash course is finished, because this is a long event, I will stop, give you guys a break, and then answer all your questions about anything. Okay, so please hold your questions for now. And I do apologize because we have to get started, but I will answer all your questions about anything after the crash course review. So just keep your hands up and write down the numbers. Okay. What I will have to do, just to keep things flowing in the right direction, I absolutely hate to do that, but I have to. I will mute everyone. Well, that's what I'll do. If there is no distractions, I'll keep unmuted. But please hold your question. Kindly hold your question because I know some people are busy and some people may have dinners and things to do, and I do not want to hold them back. Okay. Again, um, where do you find? I'm going to go
Please
back.
mute them.
Okay. Okay. So I will mute everyone then. Everyone is muted. The dangers with that is that if I am not presenting for whatever reason, I may not be able to see that. So what we're going to do is, if something is wrong, call the number, NP exam coach. I'll put you the number here and let me know. Ring the number, and one of my team members will let me know. Um, that something's not happening. I don't think it will. We don't need to do that because I will be paying attention. I'll put in different screen here. So first things first, guys. I want to go back to where you find today's event, and then we'll get started immediately after that. Okay. So if you just log in, go to all trainings right here, all trainings. Doesn't matter what. As soon as you logged in to your course, go to all trainings. Once you click all trainings, go to crash course review. Once you are in crash course review, click the first training of the crash course review. So I know I'm repeating myself a little bit here, but it is important because a lot of people ask, I get a lot of emails saying, where is the PDFs? Always, always, always located under the first training of each module. So this is the first training of module 6. You click here, and this is today's PDF or document that we will be covering. So day 1. Right now, I will cover strategies. You do not need to print strategies. Okay, just pay attention to the lectures, and then we'll go immediately after this. So let's get started. So here is how we'll work for today's event. The expectation is about 6 to 8 hours. I will give you a break. So when there's, let's call it about 12:30, there will be a 30-minute break. Just about. We can adjust as we go. And then we'll continue. Every 2 hours, we need a break. You need a break. I probably could talk all day long, but you need a break. I really, the goal is not to do this fast. The goal is for you to pass. So every 2 hours or so, maybe even every an hour, 2 hours, I think would be a good time. It is pushing 2 hours, right? We'll take a 10 minutes break. So walk, get some coffee, get some chocolate, whatever, get some food, and come back. Okay, so we'll get started right now. Let's do this. Very important, write it down. Everything that you hear today will be on your board. Everything you hear today will be on your board. Okay, one way or another. The concept will be on your board. Okay, so let's start with the most important strategy right away, right off the bat. If you do this, you will get 10% of your questions immediately right. Immediately right. It's not magic, but what is that? If you walk in a room not knowing what you look for and go, gee, what am I going to look for in this room? Right? You might find things that are interesting, but not necessarily what you want to find. So what am I talking about? When you read a question, please, please, please answer the question on your own words before looking for answers. That is the magic. Think about it. How many times have you done a test and go, gee, I can't believe it. I made those mistakes. I knew the answers. What happened that I picked the wrong answer? I'll tell you what happened. It was not that you were not paying attention. There was distractions. Distractions most of the times are true answers or true statements. But the problem is it does not answer the question. Example. Let's say your patient is taking a antipsychotic, whatever. Let's call olanzapine the mother of all metabolic syndrome and Clostridium. Clostridium is probably the father. Olanzapine is the mother of all metabolic syndrome. Your patient is stable and comes to you and says, somebody says, I cannot hear you. Is this true for everybody? You are able to hear me, right?
I can hear you.
Okay, thank you so much. All right. So the mother of all metabolic syndrome is olanzapine. Your patient is stable on olanzapine and comes back to you and says, Dr. Lopez, I don't have hallucinations anymore. or I don't have manic events anymore. But I have a problem. I am gaining extra weight. I got 20 pounds extra weight in the last 6 months. That is a problem. Option A, educate the patient how important it is to continue her medication since it's preventing manic or psychiatric um, psychosis. Let's call it. It's preventing her psychosis. That is a beautiful answer, right? But, and it's likely that you would pick that answer. But is it answering the question? No. So if you read the statement and says, patients gaining weight, and then you think, how would I solve this problem? I'll ask her to do lifestyle modification. So when you read the question, answer the question, now you are looking at the answers and see the one that matches or is close to what you said would be the answer. Otherwise, you may pick your distraction. The distraction was educate the patient how important it is for her safety to continue the medication. That is a true statement. And now you go, oh, that is a beautiful statement. It's option A. And now you're stuck with the answer. Does it make sense? How do you prevent that? Is answering the question and staying true to what you learned. So if you're looking for decreasing weight by doing lifestyle modification, you need to know that. It is important. You look at the answers, do not pick education. Because education is important, but it will not solve the problem. By doing that alone, you will get another 12 questions right that you otherwise would have got it wrong. The test is very clever to put true statements that does not answer the question. If the answers does not answer the question, it cannot be the right answer. Okay, keep that in mind. As you do the question bank, ask yourself, practice that, right? Practice answering the question, not picking a true statement. So here we'll go over objectives approach to questions, which we just covered one, selecting the right answers, prioritizing, safety, critical thinking, collaboration, super high yield, and cultural consideration, which again, everything is high yield, right? But the first three modules is where the money is at. Okay. So again, objective approach to questions. How do we do it? We read the question and we answer the question. It is, if you haven't done it that way, it is a mind shifting. Okay. You have to change it differently to get different outcomes. Okay. So if you do that, focus on the information that is provided in the exam. Do not look for, this is how I do it in my house or in my hospital or in my clinic. Ask yourself, is this true? The standard of care set by ANA. That is the standard of care, right? That's what they're testing. It really is an ANA test, right? Now, avoid making assumptions by adding details that are not mentioned in the question. I promise you that although all questions or some questions are unclear, not all, but some questions are unclear, what you need to answer the question is right there in the stem of the question. Or, and then you find the answers. Identify what is the core of the question. So that is what I'm talking about here today. What is the core of the question? When you read the question, ask yourself, what is the question asking me? Going back to the same example of someone gaining weight, the question is asking you, how can I stay stable and yet decrease my weight? How can you help the client? Your answer would be lifestyle modification, not education. Okay, then you formulate your best answer, right here. So you ask yourself, what is the core of the question? And then you say, what is my answer? You formulate your best answer. And then after that, it's piece of cake. Then you evaluate options A, B, C, and D. And I promise you that 70-80% of the time, your answer will be similar. Now, for module 4, therapies, right? It will be harder to do that because there's a lot of elusive terminology, or even culture will be hard. But most of the time, this works for 70% of the questions, right? And then if you do this, you will increase your score by 10% easily. Okay, practice that. All right, so that is how we approach questions. Now, you got to a question that you do not know. First warning, we had a lot of people, excuse me, that came back and said, Dr. Lopez, my first 25 questions, I didn't know anything. But I knew the content well, and I did not freak out. And then after that was like magic. Every single question, it was like I knew the answer. Okay? So what I want to tell you is, when you find a question that you do not know the answer, don't freak out. Take a deep breath. I am prepared. I am ready. I am prepared and I am ready. Narrow down to the two most likely answers. You will have an option for Xing or crossing. Two options. Pick your two best answers. When you come back and save it, right? There is an option to save. I don't remember if it's left corner of the test. Flag that question. Before you submit and move on, do not spend more than a minute and a half in any question. Doesn't matter. Minute and a half goes by, really is a minute and 20 seconds. But I'm giving you a grace of 10 seconds if you want to spend extra time in a question. You save the question, you flag the question. Then at the end, when now you're calm because you know the answers of hundreds of questions, not hundreds, but you know answers of lots of questions, you come back to the same question. You're like, oh, I know the answer now. Okay, so narrow down to the two best answers. If you do not know the answer right away, flag. If you do, still narrow down to the two best answers and you move on. Now, disregard partially correct answers as they are not the full or complete solution. So what do I mean? Sometimes questions comes with the first sentence connected by an and, but, only, and then the second sentence. If the full sentence is not correct, it is not the right answer. So for example, let's go back to the same patient that's gaining weight. Let's say that a true statement, for example, tell the patient that she is, educate the patient that she's gaining weight because the 5-HT2A component of second generation. However, it is the safest and most likely recommended for her to stay in the same medication, right? It is a true statement, but does not answer the question. Okay, so if it's partially correct, let's say that we say that, for example, a 5-2H, the serotonin component of second generation, helps patient have less EPS. However, there is a secondary benefit. They will be gaining less weight. That would be incorrect. So this is more of what I'm talking about. If the first statement is correct, but the second statement is not correct, this cannot be the solution for the question. When two answers are completely opposed, often one is correct. Again, we are understanding strategies, but our knowledge, our answer comes from knowledge. Let's say you see an answer that is hyponatremia, and that other one is hypernatremia, right? And this is about lithium, for example. When you see one answer that goes one way and another answer that goes another way, most of the time, one of the two answers is right. But again, there is a secondary way to fall into a question. Our knowledge, we answer the questions by having knowledge, okay? Examine the questions, the stem of the question. And sometimes you will find similar words in the answers A, B, C, and D. Okay. Sometimes it doesn't have to be very similar, it can be synonymous terms you will find in the answer choice. Again, we're trying to understand how the test works in our benefit, but the knowledge is what will save you. Okay. When several questions or several answers are almost identical, the weird one sometimes is the right answer. So, for example, one that I hate the most because I don't like the term knowledge is uh, kids masturbating, right? Or that sounds disgusting, right? That sounds not appropriate. That does not sound something that would be in the test. Or touching himself. Let's say the kid is 5 years old. That does not sound the right answer. But if you go to the phallic stage, the third stage of PAG, it says that naturally there is a tendency to self-discover. However, that is not in the way that adults may see it. You know, it's just, oh, I have something different. Mommy has something different. Daddy has something different, right? Oh, look at what I have and never noticed before. It is a different connotation, but I still don't like it, right? So that is a weird answer. So when all the other three answer choices kind of seems similar or going the same way, look at, you know, a possible um, weird one, okay? So for example, a good example of this would be also someone comes to the ED with manic stage and she's a female of 25 years old, right? Which of the following would be your priority at the moment or would be your priority, you know, before she's discharged? Okay. Answer D, ensure to conduct a pregnancy test. That doesn't really sound the right answer. But if we connect carbamazepine, female, we are concerned about possible pregnancy. So here's the cue. Almost, I have never seen, that is not a true statement, but I have never personally seen an answer that had pregnancy test and was therefore as a distraction. Every time you see pregnancy test, ask yourself, could this medication be the cause or would be something that I would be concerned if it is a female and one of the answers is pregnancy test? You have to really pay attention on that because if you found a question like that and pregnancy test was a distraction, please let me know. Okay. Any answers that says absolute things, nothing in life is absolute, right? Other than one day we will all perish or few things like that, but very few things in life is absolute. Question that says all, always, only, every time, never, everything. It is too absolute, right? In psychiatry, very few things, if any, it is all, only, always, or ever, or never, right? It is always a possibility that could not even be a psychiatric condition. And that is the reason why we need to know medicine. So a lot of questions that will be about, let's say you have someone comes with a toenail fungus, and your action would be to collect a sample to send to the lab. But then you go, gee, why would I do that? That is a psychiatric test. It's a psychiatric board certification. Why they would ask you questions like that? And here's the answer behind the why. Because we have to prove, or not prove, we have to strongly suggest that this may be a cause due to biological or medicine in general before we say this is a psychiatric condition. That's why we see things about encephalopathy that we'll cover today that is not in the psychiatry realm, but it's things that we need to know because it could spill over to psychiatry. So we have to first get labs, understand that the condition is not what is causing the distress, then we can focus on psychiatry. General medical evaluation is often um, incorrect, right? So if you find someone, for example, with Reddit syndrome, right? It is a female, let's say 6 months old, with decrease or deceleration of head growth. That is a medical condition. You need to refer. You should not be doing excessive treatment on that patient. Okay. One quick second here, please. Okay. So that is something to refer. OB cases, PED cases, that is something to refer. Other than that, ask yourself, can I do something before I refer? If that is the answer, if you can, then do it and then refer. Okay. When we looked at clinical priority, clinical judgment, questions containing things like priority or initial actions. What should you do first? It is priority. It is the initial action. When you find questions that says priority, immediately you go airway, breathing, and circulation. That is number one. That is your priority. That tops education. That tops assessment, even though some of that is assessment. That tops nursing actions. Airway, breathing, circulation. Example, a highly suicidal patient comes to the ED. She have attempted suicide 3 times before. She comes to the ED due to cuts to her wrist. Which of the following is your priority? Ensure that she has a good, safe planning before discharge. Ensure that she can agree to safety and will not cut herself again. Or option D, take vital signs. Because the question is priority, then you do airway, breathing, circulation, right? So airway, breathing, circulation falls into vital signs is airway, breathing, circulation. But only when the question says priority, initial action, or what you should do first. The second option, give me a quick second, folks. The second,
Dr. Lopez.
Yes.
Sorry for the interruption. While you're on priority and just going back to the pregnancy test, I remember having a question that I don't remember what the medication was, but it was a female patient who came in, and then the answer was, instead of pregnancy test, it was more of, choosing the EKG because that
Right.
medication had the
So,
impact of that would
right.
more
I
lethal.
sorry. I think I know what question you're talking about. We'll cover that question. That it was a lithium questions in AED.
Okay, yes, you got it.
Okay, we'll call. So, guys, what I will do, and then Marianne, I do must apologize for this. So I'll have to mute everyone because I kind of have to kind of go through a lot of content today. But write down your questions. I will, and I would love, and I think this is the most important thing out of anything is to answer your question. I just want to get through this content, but I do apologize and I do thank you, Marianne, for the question. It is an important question. Just remind me. I'm going to bring the question up again. Okay, so please forgive me for this. Here we go, folks. When do we do airway, breathing, circulation in priority questions, initial actions? The second, if there is not airway, breathing, circulation, then we say Maslow's. What is Maslow hierarchy of needs? Remember the pyramid, right? The pyramid, it says, hey, at the bottom of the pyramid, it is food, shelter, air, and then above that will be safety, and then above of that and above all the way to the top will be self-growth, things in that nature, right? So when you do that, if it's not Maslow's hierarchy of need, I mean, if it's not airway, breathing, circulation, think of Maslow's. Okay, think of Maslow. Is this something that talks about Maslow's, right? Maslow would be something like safety, water, food, shelter. If that is not airway, breathing, circulation, think of Maslow's as a second choice. If there is not airway, breathing, circulation, there is not Maslow's, then we have the nursing process, which most of the questions will fall under this, the nursing process, but not all. We just gave you an example of someone cutting her wrist. Initial action, taking vital signs. Now, what is the nursing process? The nurse process is assessment before intervention, right? Now, what we need to know is that assessment for us, PMHNPs, nurse practitioners, it is not necessarily going to the patient and listen to heart sounds, which is an assessment. But the core of our assessment is anything that we need in order to formulate a diagnosis. So therefore, we then can do an intervention. Examples, vital signs, we need the vital signs sometimes to justify this is NMS, right? But also vital signs falls into priorities and initial action. Let's say the most common information that we need is conducting a literature review, right? To find out which medications to give or to find out even the diagnosis. That is assessment. Another one would be labs. Very high yield, conducting a literature review could be the answer if it is priority, um, initial actions, a question, and there is no airway, breathing, circulation, there is no Maslow's, the right answer would be, for example, doing a literature research to find out what would be the best medication for this patient. Just a silly example there, okay? All right, so now we have to emphasize patient safety. Everybody knows that, but sometimes we lose track of this. So here, let me give you a perfect example. If the patient comes to you in distress and says, I was raped, coming to your office or last night, your priority is not to call the police. Your priority is not to do a rape assessment, collecting evidence. None of that matters right away. What matters is, are you safe? You are safe here. Or, for example, do you have a place to go tonight? Or can I help you immediately at this moment to make you feel safe? These are the priorities, okay? So patient safety is always important and more important than the following action. So let me give you a good example for the test. Mother calls you in your office and says, my younger child was molested or sodomized by his older brother. Option A. Now, what should you do at this moment? Option A, call CPS immediately since the child, the younger brother, it is in danger. That is a true statement. But this is a safety question, Maslow's. So option B, mom, stay with your younger child and do not leave him alone. That would be the right answer. Okay? That would be the right answer. Even though option A is a true statement,
Yes.
it does not, it does not answer the uh, it does not answer the true statement or the safety core of the question. Give me a quick second. I do apologize. I'm not sure why. Okay, should be good now. Okay, it does not answer the safety measures that we need to know. All right, so now once we fully understand that we always have to keep safety, even though it sounds a cliche thing or something that we all know, ask yourself, is this about safety? If it is, pick the safety answer. Okay? Now, ensure that the patient has a secure discharge before leaving the hospital. Never, 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 never do safety contract. Safety contract is wrong every single time. Almost nothing in the test is true 100%. But if anything, any answer that says safety contract, I can almost guarantee you would be the wrong answer. Why? AANA has put out a statement saying, do not use safety contract. Why would that be the right answer on their own test? It probably not. So what would be the right answer? Safety planning. Please write it down if you do not know what safety planning is versus safety contract. Safety contract, never. Safety planning, almost always a good answer. Okay? Conducting interview in a semi-private settings to prioritize privacy. Now, let's say you are working in an inpatient settings. And when you come to work, 7 o'clock in the morning, your nurse says, hey, Dr. Lopez, your patient has been very agitated all night long. I am concerned that he might be violent. Okay, great. You still have to do an assessment. But how do you do this assessment? It is what I'm getting the core at this moment. You do the assessment by having a semi-open door of the room, because that way you prioritize safety and patient's confidentiality and privacy to some extent. What you do not do is have an assessment in the middle of the nursing station right? Or in front of other patients to ensure patient safety and your safety. That would be incorrect, right? What you want to do is have the assessment in a semi-open room where he can escape from you and you can escape from him, okay, if they need to, okay? In cases of suspected child abuse, interview the child separately and call CPS if necessary. How? It depends how. If the abuser are the parents, mom or dad, then you separate them. If the abuser was the neighbor or the uncle, then you have the child and the family together. Okay? Now, when you do that, make sure you collect some assessment before you immediately calling CPS. So let's say now that you are observing a child playing sexually with a doll. Your action is to collect more information and then call CPS. Okay? Do not, if option A is call CPS immediately, do not pick that answer. Yes, you must call CPS, but yet you are or will be the cream of the crop. You are prepared and ready to deal with those situations. So what do you do first? You assess. Just simply by looking someone playing sexually with a doll is not a immediately strong indication for CPS. You assess the patient. You bring the patient in. Ask them, hey, what is it? I saw you playing with doll in a different manner. What does it mean? What happened? Get more information and then call CPS. Okay? When dealing with teenagers, this is a hard one. When dealing with teenagers, you gain trust and rapport by ensuring confidentiality, right? Unless there is a serious risk. So let me give you an example. If Mary, that is a 16 years old teenager, female, comes to you and says, hey, doctor, I want to tell you something. I'm like, please tell me. Oh, I have been dating another 17 years old female in my class. Please don't tell anyone. So what is your action? Keep the information confidential. Do not tell the parents. Okay? So let me give you an example. If a teenager says to you, I'm smoking, please do not tell my parents. Do not tell the parents. Now, let me give you a different example. If the teenager comes to you and says, I am having intimate relationship with a male that is 25 years old, now it breaks the risk and allows you to break confidentiality. That is not something you want to keep confidential, right? Anything that is highly, anything that is a risk for the patient, you have to break confidentiality, right? If the teenager says, I have suicidal thoughts, that is not, and please don't tell my parents, they will be very harsh on me. That is not a reason to tell the parents just yet. If they have suicidal thoughts plus a plan or intent, absolutely. Okay? Interview the patient in a private room to maintain confidentiality. So right away, pay attention to this rule. Okay? It's about confidentiality. I'll go back to the private, well, let me talk about the privacy of the patient. If they, if you offer to have an interview with them alone, may be helpful. Let's say there is a boy, his name is John, and he was, let's say he was raped, but he's 16 years old, do you think that he would like to tell the parents and having this conversation in a parent with the parents in a room, offer them a privacy to talk about what happened? Okay, unless if they say no, I would like my parents to be involved in a room, then it's okay. Teenagers sometimes do not want to talk about their problems or what happened in front of the parents. Okay. And this brings a ethical dilemma. So what is the ethical dilemma? The parents needs to know, right? Because the parents needs to know they're paying for versus maintaining confidentiality. Okay. So I know you are put in a hard position, and then you think as a parent, most of you guys, and you say, oh yes, I would like to know what my teenager is doing, right? But that puts you into this ethical dilemma, which is called the parents needs to know versus maintaining confidentiality. Okay. All right. So we cover quite a bit here. Let's move on. Importance of critical thinking. So many students have come back to us and says, hey, the content was on point. Everything you taught us, everything we went over was on the test. Now, it is very likely, and they come back and say, but you have to use critical thinking, right? So nothing is word for word in the test. But a lot of things that we talked about here today and tomorrow will be on your test. Understanding the clinical reasoning behind your decision. Why would you be asking for more labs, right? What will do to you finding out those labs or imaging? You know, what are you trying to gain out of that? Okay. This is super high yield in many forms. Anytime you see collaborating, your ears should puff up and say, likely the right answer, right? So collaborating with who specifically? Emergency department. Collaborating with who? OB department. OPs. These are the three most collaborate. Sometimes dietitian too. These are the three most popular: peds, OB, ED, peds, and dietitians. Okay, if you see that, you should be thinking, that sounds like a good answer. Okay, so when you have a chance, or always, do not delegate. If you have a options to involve the nurse manager, involve the dietitian, involve the supervisor, are much better than just contacting the dietitian alone, or contacting the nurse that did a mistake, or contacting the manager alone. So the more you can do full collaboration, the better it is. The key here is collaboration, right? So in case of postpartum suicide risk, collaborating with the OB department is necessary. How? By asking them to do a PHQ-9 or PHQ sort of assessment before they discharge, because we know postpartum depression, it is real. Okay. Ensure consent is obtained when transferring a patient or making referrals. For example, if the patient is going from your level of care to a lower level of care, do not give the patient the documentation by hand. What you do, you fax the documents over to the new health care facility, because that ensures privacy and ensures confidentiality, and ensure that the documentation goes where it needs to go. Now, when you have a patient that there is a psychiatric condition, major depressive disorder, and alcohol or substance use disorder, or any substance use disorder, you need two consent forms, right? A consent form for psychiatric condition and a consent form for substance use disorder. How many? Two. Okay. Before before transferring a patient, ask yourself, is that something that I can do for the patient, right? If it's not an immediate safe risk, ask yourself, can I do a lab to help going forward? However, I want to call attention for this right here. Okay. This is very important. If you see a teenager um, inhaling, not ingesting, inhaling acetone, the action is to send them to ED because they could go into cardiac or pulmonary distress. Okay, not necessarily collecting labs in this instance right here. Okay, usually if it's not life-threatening, collecting labs before referral is something that you can do to advance the treatment. Okay. In this case here, someone inhaling acetone, the action is to send them immediately to the ED, not collecting labs. Please understand that. Okay. Cultural questions, very important. Tons of it will be on your test. The core of this is answer the question that is reflective of cultural sensitivity, even if you personally do not agree. We can talk about your feelings and how you think things should be after you pass the board. For the board, sometimes you have to pick uncomfortable answers. It's true, I am uncomfortable. Do you honestly think if someone comes with an arm infection, if he's rubbing leaves in his arms, and I see that there is an infection, my mind immediately is collecting samples so I can start a antibiotic. It is not in my mind before the board. Is not tell me what does it mean in your culture. The answer for the board is what help me understand what rubbing leaves in the child arms helps what it is in your culture. That is the answer. There is not collecting labs, is not studying fluids, is not doing vitals. That is not priority question. That is a cultural question. When you have a cultural question, how do you know it's a cultural question? The question goes out of the way to say that he is from Puerto Rico, or he is from Jamaica, or he is from Korea, right? And often we'll say things like they cannot speak English, or maybe even things like, come a child comes with a mother, and the mother is concerned um, about an evil eye, right? Or having a red bracelet, and then the answer is, and it comes with symptoms. The answer is, help me understand how this red bracelet protects your child. Educate me. That is the cultural answer, right? So we have to clarify culture within their own ways of seeing the world, right? With their own context of the illness or challenges. If I wake up in the middle of the night and I go for a run, and that is normal in my culture, that is not a psychiatric condition. Okay, because we want to empower the patients by understanding their prospect and validating their symptoms within their cultural framework. In other words, how do you see the world is how I want to take care of you. Okay, example, if a somatic patient panic complains about medical condition or symptoms like stomach ache after a traumatic event, you validate the symptoms. You do not go, the patient is likely exaggerating because anxiety does not cause heart rate to be 150, right? Usually it doesn't, but in some case it may. All right, so was the first hour for today. Now we are going to get into the bulk of what you need to know to pass the board. So give me a quick second here to pull up my uh, today's event. Lots of it will also be repeated between today and tomorrow, and some, even in today's event, will be repeated. Okay, so just hanging in there, there is a reason why it is being repeated. Let me increase this this presentation. Give me a quick second. I am almost done, and I'll start presenting in the second. Okay. All right. So you have this document available to you under the well, let me move this here so that way I can look at you. Okay, under the crash course review. So if you are able to see the document, please just put a thumbs up for me so I can know that we are tracking here. Okay, if any moment you are not able to hear me, or I'm talking and I do not have a presentation, gives the thumbs down so that way I can understand and get the cue. Okay, because I'm looking at you on one screen and I'm looking at this presentation. I'm absolutely honed in into this. So we covered lots of the strategy. I'm not going to go over again. This is just a summary of what we just did. All right. So folks, pay attention. Everything that we cover from now on, even what we covered before, will be on your test. Second point, you will pass the board. That is not negotiable. That is not a if. If you follow what we are asking you, you will pass the board. Point blank. Start with cultural sensitivity. So we said, hey, cultural sensitivities, rituals, habits, sleep habits, singing practice, we have to honor those. Now, let me give you a scenario that I am very uncomfortable with. Okay? Patient comes to you and he is Native American. He has a healing stick. Do you honestly think that I am going to admit a patient with a healing stick? Most likely not. Again, this is a cultural question. For the board, I have to admit the patient with this healing stick. I'm not saying that I would not in real life, but most hospitals would have a policy, would prevent, I would have to go to administration, I would have to do probably a whole day of explaining why to admit this patient with a healing stick and balance his culture and possible risk and make a decision. But for the board, you don't have to go through this excessive amount of explaining. What you do, you admit the patient with the healing stick. You do not remove the healing stick. Point number one. Point number two is that we'll cover that later, but I want to give you the example now since we're talking about. The nurses are complaining about the healing stick. That is unfair. Your action is to educate the nursing staff about cultural sensitivity and what the object means to the culture. Question number one. So now you have numbers right here that you can refer to, and we can talk about the scenario or whatever is in your mind later. John, number two, is a female. She wants to be called John. For God's sake, call her John. Whatever she wants to be called, please do it. Okay? It is not the time for anything else. It's the time for the patient. If she wants to be called John, call her John. Okay? No big deal. Whatever she wants to be called today, whatever her preferences are, we honor that. Okay? Our job is to a lot of time put our own personal beliefs in a back burner, and we do culturally sensitive healing magic in some ways, which is listening and honoring what the patient asks, if it's reasonable, right? Someone wants to be called Mary, John, Thomas, whatever, call them whatever they want to be called. Okay. Now, number three, a daughter brings her father for evaluation. It could be the mother too. Okay. The daughter brings her mother or her father for evaluation. The father has been isolated for the past 2 weeks and does not speak English. What would be your action? Which of the following would be the best answer? So anytime you see someone that does not speak English and have an issue, request a qualified medical interpreter. Even if that is true, I speak Portuguese. And in the medical field, I legally should not be seeing someone that is from Brazil unless if they have problems understanding English, right? In Portuguese, because that is the job a medical qualified interpreter, right? I mean, not to say that in real life I would not do that, but the legality of it is that I should not. For the board, again, you see someone that does not speak English, have hard time understanding what you are saying, request a qualified medical interpreter. Point number four, I just came back from Asia, not just about, it's been about 5 months or 4 months ago. I was there for 2 years, right? And I really got this. When in Asian culture, respect means this, not looking at you in the eyes. That is disrespect. So if you have someone that is from the Asian population and they request to involve the family is so high yield. You know, when I was there, many of my patients would say, I have to take care of my parents. They're 55 years old. So they really leave the house, get married, but their father and family is still the core of their family, right? So family, if they ask for family to be involved, the parents, even though they're adult and married, they have kids, honor that. If they do not look at you in the eye, it is a sign of respect, not disrespect. Please notice this, okay? This is not avoidance or disrespect. For Asian population, yoga, tai chi, breathing exercise, it is so core to what they do. If they request that, honor, because now you are balancing the energy, they focus on energy. So these are 3 points that we cover for Asian population: eye contact, honor family, and if they asking things like yoga, tai chi, breathing exercise, provide them with evidence base. Don't tell them it is not advised at this moment because you have major depressive disorder. Okay. Native American. Okay. So they have a highest suicide rate. So that is the first point you need to know, folks. If the question asks about suicidality and they have ethnicity or I wouldn't call race, so call ethnicity or race. Let's call it ethnicity or race. And they have Native of American. That is the number one to be concerned. I know most of you guys will be thinking Caucasian. Most likely would not be in the same question. But if you see Native American, understand they have the highest suicide rate. Why? Oftentimes they view dying as a natural or connected way to nature, leading to a less um, instance of asking for help. Or they sometimes see as a passages. I do not like it. They see it as naturally accepted, right? Because maybe not so much as emotional expression, maybe culturally accepted. I'm not saying that suicidality is culturally accepted, but it is more tolerated than other cultures. Let's put that way. Okay. But 2 points here. You actually have two questions in one. One, Native American. Number one, ethnicity or race, I guess, that you want to be concerned of, Native American. And two is how they view suicidality. This could be two questions in 1 point. Number six, when the child is dying, for God's sake, please let the parents grave however they want to grave. You do not tell them what's right. You do not tell them how to improve the graving. You do not tell them the room needs to be cleaned. I have to take the baby to the morgue. Please allow them to grave however they want to grave. Do not say you can have another child. Please do not say that. Okay? They know that. That is not the point. Someone is dying. You allow them to grave however they want to grave. Okay? Point number two, those that goes through distress, intact family resolve those difficulty times a lot easier. Please write it down. 2 points in one. Point number one, allow them to grave however they want to grave. To grieve, not grave, grief. Point number two, intact families handle difficult times better. Please write down point number two, which is related to point number six, not necessarily dying, but traumatic events. Okay, so 2 points in one here. Point number seven, we talked about this, Hispanic cultures considerations, right? Let's give you a scenario. After a loss, right, the patient reports, oh my God, my stomach pain, it's killing me, right? So basically we had an incident, traumatic incident. Now we have the symptoms and there are somatic symptoms, okay? Your option A, explain to the patient what is adjustment disorder, right? That is a true statement. It may be something that you need to do, but remember, this is a cultural question. So in cultural question, we are going to validate his experience and provide culturally sensitive care. I do not know what's like that you are going through, but I can only imagine it is very hard. Don't say you know what they're going through. Have you lost a mother? Have you lost a child? You don't know that. I don't know that because I have not gone through that. So don't pretend that you know something that you don't. You can only imagine how painful it is at this moment. Okay? Oh, and you can validate them by saying, I see that you're having a lot of stomach pain. Help me understand what it's like in your culture. Things along those lines. Or help me understand your symptoms better. These would be the right answer. It would not be the answer. This is an adjustment disorder because you see the traumatic event, the symptoms, right? One could diagnose this as adjustment disorder, but it would not be necessarily the answer. Okay. Now, let's say we have a Nigerian man, 16 years old, who recently migrated to the US 3 months ago and presents with somatic symptoms or things like, I think too much. Write that down. I think too much. There is a cultural bound syndrome. So what do? If it's a cultural bound syndrome, It is not a psychiatric disorder. So what would that be? That what we do is provide brief supportive therapy. Help me understand what you mean by I think too much, or providing things that would help him be more at ease. So understand Nigerian culture and cultural syndrome, the meaning of I think too much. So write that down. Number 8, I think too much. It is a cultural bound syndrome. What you do, your actions to provide brief supportive therapy. All right, let's move on to number 9. A new provider identifies multiple hospital errors and needs correction. You've been assigned for this project. Are you going to go there and develop a policy to fix those errors? What will be your first action? Your first action is assess and evaluate what is happening. It's not to go immediately to develop a policy or a plan of action. Your action when you are provider assigned to the new hospital to correct medical medication errors is to first assess and evaluate the problem. Is not to create a policy or a plan immediately and put into effect. See, those are the type of the answers that if you read the question and answer, what would I do first? You do not have to get bogged down by distractions or distractors answers. Okay, so please pay attention on that. In quality assurance, anytime you hear quality of care or quality assurance, you think of two things immediately every single time. What are the two things we think? One is retrospective chart review, retrospective chart review, and the other one is PDSA. We'll cover PDSA later, but anytime you hear quality assurance, you say two things: retrospective chart reviews and PDSA. Now, why do we do retrospective chart reviewing? Right? We do this to establish a criteria for quality of care. We go back in the charts and see what was done and what was the outcome. And we establish criteria to help decrease cost, improve system, and deliver uh, top-notch healthcare. Okay, so anytime we hear quality improvement, we think retrospective chart reviewing, audit, or PDSA. Number 11, interprofessional delegation. So let's give some example. As the PMHNP gets involved rather than asking the nurse manager to delegate tasks. So example here, we have a patient that is anorexic or have anorexia and needs a diet plan. Instead of necessarily developing a diet plan, we would collaborate with the team. We would not ask the nurse or the CNA to do a diet team or diet program for the patient. Okay, so we would involve the dietitian, we would involve others and collaborate with the team. Yourself calling and arranging things. Do not ask someone to do something that you can do for yourself. Example number 12. Let's say you have a man that comes in and his blood pressure is through the roof. I am concerned. 155/99. Very concerned. But he does not have necessarily chest pain or acute symptoms. How you feel? I feel well. But your blood pressure doesn't say the same thing, right? So what we want to do is not ask someone else to arrange for a visit to PCM. We want to call the PCM directly. We call, we arrange, we make happen, right? We get involved. We do not delegate this task to the nurse or the CNA, okay? Another example, collaborate with OB provider to build relationships and improve access to mental health. Every time you hear OB involved, what do? We do to build relationship and improve access to mental health. Why do we have a PMHNP in the OB team? We do this to increase mental health access to those in need. That is two questions in one. Why would the PMHNP be involved with the OB cases? For example, let's say you are assigned to an OB department. Why would that be? To improve access to care to those in need. Okay? Anytime, second question, anytime you have a collaboration with OB providers, that is most likely the answer, because collaboration is high yield. Number 13, a patient admitted for opioid use and is being discharged to a rehab facility. Labs are completed. Are you going to give the labs to the patient? You are going to fax the lab results directly to the rehab center, right? Why? Well, you want to avoid them, avoid giving them to the patients, so he may lose, the facility may not receive what they need to initiate treatment. So the better way, how do you maintain confidentiality? Faxing. Now, the sad news is if you fax to the wrong number, you did not break informed consent. You broke confidentiality. Let me repeat. If you fax drugs or information to the wrong number, you have just broke confidentiality. Never informed consent. I would write that down. That is high yield and may come in handy another time. So it is a breaking confidentiality when you fax medication to the wrong pharmacy, for example. In this case here, you want to ensure confidentiality by faxing the lab result directly. Okay, so we want to fax this directly. Okay. All right, safety first. What do you do initially? Every time is safety, right? Assess safety. Okay, so let's say a patient overdose on a antidepressant and comes to the idea running. I cut my wrist. I was trying to hurt myself. Your plan is not to ask what her suicidality is, what are causing her distress, or if she has a safety planning. As we mentioned before, now it is an initial action. What we do first is ABC. So what is ABC? Vital signs, right? We ask for vital signs, right? That would be part of your initial assessment. Number 15, a 15 years old report being raped. Oh my God. So the mother is present. Would you do an assessment with the mother, father, or neither? The answer is, hey, ask them if they want privacy. That is a 15 years old, right? They don't want to talk about sexual problems in front of the parents, or maybe most would not. If they do, thumbs up. If give them a choice, or if there is an answer to interview them separately, pick that answer. Okay. Nurse number 16. Nurse reports the patient was aggressive overnight in the inpatient ward. We talked about this. Interview the patient in private, same open door, safety area, right? So we want to do honor confidentiality and privacy, but not to the extent where you would be in harm's way or the patient may be in harmful ways. Okay. Number 17, a patient reports feeling terrible and believes that the group home is poisoning my food. What is your action? Contact the group staff and notify police about the active homicidal intent. Good. Here are a few things. One is, do you call police? Do you call the State Board of Nursing? Or do you call the possible victim? Let's look at this example because it does fall into a different category. So here we have a patient that is feeling terrible that the group home is poisoning his food. Do you think he is in a sound, perfect state of mind? Probably not, right? In that case, you need to alert the group home and notify law enforcement, right? Because there is an immediate threat that could affect 50, 100 um, other folks inside of the group home. Who knows how big this group home is while everyone is sleeping, right? It is a little bit different than the pure Tarasov principle. We'll talk more about that later, the Tarasov principle. Number 18, we have a 3 years old that is brought because her mother thinks he is oversexed. What does it mean? She is preoccupied with a woman's breast and has been masturbating. For God's sake, he's 3 years old. Okay, he's 3 years old. It is normal. It is the phallic stage according to Fyodor, right? Leave it at that. For the test, you pick phallic state, you pick it's normal. It is normal for the test, okay? It is normal. Now, we're not going in real life. Okay, we just test focus. So we have a 12 years old that cries frequently, isolated, and has no friend. Look at the age. What is the age? What is the age? He's 12, right? So immediately we gotta think what stage of development the person is. And he isolated, has no friend. He's doing poorly in school. Erickson, it is very important. Identity versus role confusion, right? He is 12 years old. So in Erickson, if you memorize the ages, it will help you so much. One that you need to know is identity versus role confusion. Okay. He has not successfully mastered this stage. Number 21, 22, 23. We have to know cranial nerves. I would be inclined to say, yes, you have to know all 12. But some of you guys may not want to know all 12, and I do respect that. Let's start with most high yield. Number 5, the muscles of mastigation, right? It is the trigeminal nerve responsible for biting and chewing. Number 5, you need to know number 5, okay? How about puffing out the checks, puffing your checks? What would that be? That is 7. 7 is high yield. 5 is high yield. How about checking the tongue for tremors? That is different, right? Assessing the patient to stick out his tongue and saying, ah, that is number 12. Okay, that is number 12. I even would put here um, number 11, right? Um, as an important one. Okay. Now, here's the example that I gave you earlier. So you see a lot of what we covered earlier is coming back and the will in different ways. Okay. So if you have someone that comes to you with a fungal appearing toenail, that's not psychiatry, folks. Well, we have to rule out medical conditions before we treat psychiatry conditions. So what we do, scrape the toenail and send a lab before starting treatment, right? We wanted to send a sample to the lab. Number 25. So many people ask about this question. Macro, big A, means lack of B12 and B9, right? So macronemic anemia requires rule out the B12 and folate deficiency. It is most likely what is wrong. So what are the two labs that we'll ask for? B12 and folate. What is folate? B9. So let's talk about folate a little bit. So folate can also, you may come in handy when someone is taking a mood stabilizer and even psychotropic drugs. If they're a female, childbirth, age, which is for the test 12 to 50, write that down, that is important. Okay, 12 to 50 is child ages related to possible birth for females on the test. Okay, so if they are taking a Depakote, you want to add folate, or if they are taking really any other psychotropic mood stabilizer or antipsychotics, folate would be probably a good initiation. But when we talked about macrocytic anemia, we would look for labs like 12, B12, and B9. How about MI, microcytic, right? Anemia. Look at the eye. Somebody taught me this, I think, 2 weeks ago. The eye means, the connection, I never thought of this way. She said, think of the eye as iron. I was like, oh, okay. That makes it a little bit easier to remember, doesn't it? So what we want to do, ferritin first, right? So association is helpful, right? If you think of the eye, think of iron. So that way, why is it here? This is not, I wouldn't say that it's not, but it's not as high yield as this one. But the reason why this is here is that you do not pick iron studies when they are asking specifically for this. Okay, so when they ask for macrocytic, you pick 12, B12, and B9. If for the event they ask microcytic, then you pick iron studies. Now let's convolute things a little bit. In real life, folks, you would ask for both. You would ask for iron and B9, B12. But for the test, if it's very specific, then that is the answer. And that's what we are doing today for the test. We're not going to talk about real life because it can get things messed up. Now, again, tests love this one. It says, hey, this buff guy, it's working out every day. And now he comes to you complaining of a cherry color, oftentimes that's Coca-Cola. That's loves to call it Coca-Cola-like color urine. You think myoglobinuria, right? And myoglobinuria, which is rhabdomyolysis, right? So we think cherry color urine, we think rhabdomyolysis, right? This is a rhabdomyolysis. What gives away is the muscle breakdown, right? He's in the gym, working out, not hydrating. Now he has probably uh, blood on his urine. He has this very dark color urine. It is rhabdomyolysis, right? So why does it happen? Well, because there is a breakdown of the muscles. When that happens, the myoglobin in the bloodstream goes into the urine, right? Myoglobin can damage the kidneys and require a rapid identification, right? Which what we do, if you've been in the med surg for more than a year, give them a liter of fluid every few hours, unless if they have CHF, right? And monitor urine function. Almost never, this is the answer for the test, but the answer is to realize someone working out, poor hydration, or taking a lot of supplements that come back with the urine colored um, urine colored um, sample, right? Think of rhabdomyolysis. What else we think about rhabdomyolysis? Think of someone with a substance use or HIV kind of a substance use abuser and working out heavily. Again, working out heavily is high yield for muscle aches. With muscle aches, think of rhabdomyolysis. So if in the same example before, if you think of the lab, someone has rhabdomyolysis, what kind of labs we would see increase? CK, OCK, and B, right? There are several types of CK labs, but CK, I said MB, MM. There is CK, MB, which is a different type of CK levels, but we will see with rhabdomyolysis increase in CK total and CK-MB. Okay, think about adolescent who abuse substance. Oftentimes will be related to IV usage. Okay, number 29, Depakote. If we have someone on Depakote, okay, and they come with dark urine, first, if we see someone on Depakote, we say pancreatitis and liver toxicity. 2 FDA warnings, pancreatitis, liver toxicity. Immediately, every time we hear Depakote, we say pancreatitis and liver toxicity. Now, the signs comes with dark brown urine, connects to Depakote, right? It connects to Depakote, and then concern for liver involvement, right? So we should be concerned about that. What do we do? LFTs, liver function tests. Now, the first thing to do is to stop the medication. Every time you are concerned about something serious, that is your first action. Second action is ask for a liver function test. Okay, Depakote can cause hepatotoxicity, right? Which may have a dark urine, may indicate bilirubin metabolism or liver injury. All right, number 25, 30. We have a patient that it is on Depakote again, and he presents with possible liver toxicity. Again, how could that be presented as far as signs and symptoms? It's something that you need to know, okay? They oftentimes present with abdominal pain, jaundice, and nausea. And now we connect to liver toxicity because it is Depakote. And what we do, we send them immediately to the ED for evaluation. So this is a typical case that they call you and say, hey, Dr. Lopez, I have a schedule with you for next week, but I just been feeling nauseated lately, and I have this abdominal pain, and I just feel and look different. My wife says that I look yellowish. I just want to let you know that I'm coming for my appointment next week. No, 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 no. You are going to the ED immediately. Of course, stop the medication and send him to the ED. Very important. Okay. This is usually a call. You receive a call cases, right? And then here, what is testing you is your ability to connect Depakote, liver toxicity, and action, all in one question. Three components to one question. That's what they're testing you. Can you understand what are the FDA warnings for Depakote? And if you so, what would you do? Okay. So what do you want? Because some people like to understand why would they ask questions like that. Patients taking Depakote and present with Depakote again, with pancreatitis. They would never say pancreatitis. It would say, oh my God, I have this sudden upper quadrant abdominal pain that spreads to my back, and you're feeling nauseated and vomiting. The same thing usually is a call. So it usually is a call and is assessing, do you recognize Depakote, liver toxicity, and pancreatitis? And they'll give you the symptoms. They will never say liver toxicity, and they will never say pancreatitis. So they want to know, do you understand what is Depakote? Do you understand liver toxicity? What are the signs and symptoms? Do you understand pancreatitis? And finally, what is your action? Stop the medication, send them to the ED. There is not time for, I'll see you next week. Your action, send them to ED. Number 32, erythromycin. For God's sake, every single time you hear erythromycin, clarithromycin, or any other antibiotic, you think inhibitors immediately. I don't even tell the rest of the question. Every time I see those, I'm like, inhibitors, right? Even in real life, which doesn't work as much as that. Anytime you hear, it's not all antibiotics, I'm being a little bit exaggerated, clarithromycin, erythromycin, Flagyl too. Okay, think inhibitors. Now I have this inhibitor, and it's taken with carbamazepine. Why would I be concerned at all? Because it will increase carbamazepine levels, and now I am concerned for a granulocytosis, right? What else am I concerned for? Aplastic anemia, right? But which is the two FDA warnings for carbamazepine. Write that down: aplastic anemia, agranulocytosis. So if I have a inhibitor plus any medication, it will increase the level of the medication. So now it is important because option A will say things like erythromycin is a inhibitor, therefore cause a carbamazepine levels to rise. That is important, and that is a true statement. Does this answer the question? The question asks you, patients taking erythromycin plus carbamazepine, what would be your next action? The first option is a true statement, but does not answer the question. The next action is to decrease carbamazepine or tegretol to avoid toxicity. So that is a perfect example of a true statement that does not answer the question. You have to be very careful because lots of questions comes with true statement. But if it's not answering the core of the question, it is a mistake to pick that answer. Okay, since we talked about inhibitors, so it's a good time to do a little bit of a teaching. Top five, I wouldn't say top five, but at least top three here. Okay, so top three, any type of antibiotics, erythromycin, clindamycin, antibiotics, right? inhibitors. Okay, another one. The father of all inhibitors for at least mood stabilizer, Depakote. Anytime you hear Depakote, you say inhibitor, inhibitor. Especially, this is a question that will be on your board, I guarantee you. Okay? Guarantee you right now. If you see Depakote together with Lamictal, no, never. Okay? It will increase Lamictal level, sometimes even double. Okay? So two things to remember. Depakote is a inhibitor. And second thing is never give, okay, maybe I shouldn't say never. I would say should be concerned with Lamictal and Depakote together. But now you remember antibiotics and inhibitors, valproic acid and Lamictal should not be given together, preferably with, so we have to really, really decrease Lamictal levels. And ketoconazole, it is also another high yield inhibitor. So these two are inhibitors, but it depends which CP450 we're talking about. Now, what inhibitors do, they will increase the level. And what is the problem with that? It will cause toxicity. For example, here, erythromycin, clindamycin, with carbamazepine will cause a granulocytosis, aplastic anemia, or aplastic anemia. Depakote with lithium, Depakote will increase lithium level. Why do I care? Because Steven Johnson syndrome. That is why I care. I care a lot, actually. Okay, if Depakote is the father of all inhibitors, the mother of all inhibitor is carbamazepine. Oh my God, this one inhibits itself. Okay, it is something outside the books. That's why I do not like to prescribe this medication, because it will disturb all other medications. It will bring them down. Carbamazepine brings them down. Okay, so think of rifampin and tobacco smoking. Okay, yeah, phenytonin is definitely a inducer, and phenobarbital is definitely an inducer. But I'm more concerned about rifampin, and I am concerned, super concerned with carbamazepine. Now let's talk about the classic smoking question that you will see on your test. I told you that you will see Depakote and Lamictal. You will see erythromycin, clarithromycin with something else, doesn't matter what it is. You will see this example of smoking. Okay, smoking is not necessarily the nicotine, but the burning that is a chemical in there that causes olanzapine and chlorazil and even Seroquel and others as well. But classic for all board questions, don't even care which one. Smoking will decrease the drug levels, right, of olanzapine and clozapine. Now, most likely, who cares? They don't care about that. They care what will you do, and that is when you need to shift your thinking, what it does for what is your action, so that way you get the question right. So what do you do is, knowing that smoking is an inducer. Oh yeah, this is important, guys. It's very important. Okay, what type of inducer? For what type of inducer? The clozapine and the olanzapine, which is a 1A2. Please write down. Smoking, it is an inducer, but you need to know, a second question is that clozapine and olanzapine is a CYP 1A2. CYP 1A2. That is 2 for 1. Okay, 2 bullet point, 1 bullet point for 2 questions. So clozapine and olanzapine is CYP CYP1A2. So what smoking will do to CYP1A2 is to lower the drug. So what I care your actions, right? Your actions to increase the drug. Now, there is a variation of that question. Patient comes back to you and says, you know what? I recognize that living longer is more important than having my puffs every day or smoking every day. So I decided to quit, Dr. Lopez. I'm very proud of myself. And I say, oh my God, so I have to decrease the drug when the patient if the patient stops smoking, the drug level will sorry about that, will decrease. So the drug levels decrease, right? Which now your action is to decrease. I'm sorry. So if the patient stops smoking, the drug levels will increase. Your action is to decrease. All right, I was a little bit fast here. Your action is to decrease the drug. Okay. So I almost thought I made a mistake, but I didn't. I just didn't read all the way through. So what is your action? Your action should decrease. Okay. So please know that that is a very classic example. So smokers on olanzapine needs a higher dose. They quit smoking in the hospital. Clozapine will increase. You need to decrease the drug. Okay. All right. So 32. A patient on a oral antibiotic. Oh my God, this is oral antibiotics, right? So think of this and patient develops an infection and started on a oral antibiotics 14 days earlier, right? So usually how it comes every single time. Patient is stable on X. Let's say stable on, doesn't matter really. Lamictal, and started a oral, well, let's say antipsychotic. So it's oral, had an infection. Okay, let me come back here. So if the patient had an infection and started on a oral antibiotic, okay, now what is your action? To decrease the drug to prevent toxicity. Remember that you don't have to know all of the oral antibiotics, but know that in general, when we think about antibiotics, we think of a inhibitor. And what we need to do is to decrease our dose of antipsychotics to prevent toxicity. Okay. Now, the question will likely be: patient is stable on X, Y, and Z in the last 2 weeks, felt a cough or some kind of a fever, went to the hospital. The PCM started on a antibiotic. Now the patient prevents with blah 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 toxicity levels, and then you connect antibiotics will inhibit the breakdown of my medication. The symptoms that the patient is presenting is a toxicity level. What do I need to do? Decrease the drug. Okay, so I'm giving the breakdown, and if you understand the breakdown, you will easily get the question. Okay, so the rationale is many antibiotics, specifically erythromycin and clarithromycin, are CYP inhibitors, which will increase antipsychotics level. Not all there are um, there are the same CYP, but in general, yes. And if that happens, they may have excessive sedation, EPS, prolonged QT prolongation, and other symptoms. So what is important? To reduce the antipsychotics dose. Okay? Number 34. A patient has been stable on Zyprexa or Seroquel and is a long-time smoker. Okay? So he began smoking cessation. So what do? Again, you decrease the dose of olanzapine. Okay, those like Brexit. Why? Again, once again, CYP, clozaril, olanzapine, Seroquel, they all get involved. All right, number 35. A patient takes Flonase daily for allergies. Now, he is diagnosed with bipolar disorder. And needs to start on a mood stabilizer, right? So which mood stabilizer decrease the effectiveness of Flonase? Please pay attention. It is not asking you what will Flonase do to your mood stabilizer. It's asking you which mood stabilizer will decrease Flonase. So it's the inverse relationship from what we usually see, right? So who's the mother of all inducers? This guy right here, or this gal right here, I would say, right? Carbamazepine induces everything. So it will decrease the Flonase level. Now, other questions that you may see is, patient is stable on lamictal. Patient is stable on carbamazepine. Recently, he went to the PCM, and the PCM started Flonase, which is a steroid. And now he's complaining of fast speaking, disorganized thinking, X, Y, and Z, right? So what is possibly the problem? Now the problem is the Flonase, because Flonase is a steroids, and these steroids cause mania. Okay, but the question here is asking the other way around. Is asking you what this mood stabilizer, carbamazepine, which induces everything, will do to Flonase. Reverse. Okay. All right. So a bipolar patient has been stable on carbamazepine for a long time. The PCN. Oh, I just spoiled the question that I was going to cover here. So a bipolar patient was stable on carbamazepine. The PCM recently started Flonase for his regimen, and he now presents to a manic stage. That is usually the classic way the questions are presented. So what is the problem? Flonase. Now, here is what you guys need to know. When you get a question like that, you have two options. Okay? All right. In this case, you increase your psychotropic drug. Number one, your action. So your action here is to either increase your medication or collaborate with the PCM2 DC Flonase. Okay, usually the answer is this right here. Usually, okay, but if this is not here, you pick collaborate with the PCM2 DC. To DC Flonase, okay? All right, so many corticosteroids, even inhaled or inhalers, can precipitate mania, right? Hypomania, agitation, psychosis. So the problem here is not, one of the problems that many students think that steroids is an inducer. No, it can induce, can increase the incidence of mania or hypomania. Okay, and depression, right? But now, the question that I get all the time, how do I know that it is a steroid? For God's sake, Dr. Love, I get this email at least once a week. Okay, same thing. I am so stressed. I'm like, okay, what is the problem? Do I need to know all the steroids? No, you don't need to know all the steroids. I'm providing to you right now. Top 5, 6. Prednisone, methylprednisone, prednisolone, dexamethasone, fluticasone, hydrocortisone. You don't need to memorize none of that. That is all useless information. What you need to memorize is one. They all finish with one. Okay? O and E. If I would have memorized this, but I mean, you would know, right? Because you've seen all of them in MedSurg and you'd know this. But all of them, what do we have in common here? One, O and E. Although some may have a little bit of variation of that, most of them is SONE. But we have a natural variation that is just a testosterone, ONE, and we have LONE, right? But if we want to summarize it, ONE means steroids. And steroids, what does it do? Cause mania. Steroids, what does it do? Causes depression. So causes both things. So if you find prednisone, Flonase in the question, and the patient was stable, now the patient presents with mania, or the patient presents with depression, then you know the problem is Flonase. What you do is increase your medication or collaborate to DC the steroid. Okay, 37. Now the patient is taking lithium, and for a little while, but he develops this back pain. You notice that the PCM recently prescribed Motrin, 400 milligrams CID. Now, guys, this is a high yield question because it's always the same thing. Patients is stable on X, Y, and Z. Something was added. Then you got to be like, oh, what was the something that was added? Motrin. And you got to think, what is the relationship of Motrin and lithium? Motrin increase lithium levels for the test, possibly inducing lithium toxicity. So how do we know this is lithium toxicity, or most likely severe? It's a severe. No medication has a side effect that is severe. When you see severe, think of toxicity. That is good for all questions. If you see severe, excessive, non-stopping, you got to think toxicity. Okay? So lots of components in one little bullet. Now, most likely they will say patient presents with cursed hand tremors. What is that? Well, it's the one that you can see. If you can see, it's coarse. If you cannot, it's fine. And fine is side effect. Very different. Toxicity and side effect. They may have slurred speech, confusion, severe GI symptoms. Oftentimes they may say metallic taste, not very high yield. Okay. Now, what we need to know that is super important, NSAIDs, oftentimes said is to be Motrin or Indocin, right here. Okay. So pay attention. It may not say NSAID. It may say one of these two, or a variation of that, right? There are several variations. Now, what we need to know. Okay. 38. We know lithium levels, it has a narrow therapeutic window. Okay. So why do we care? Right? So normal, right? Let's say normal here. So this is what we want. We want to live between 0.6 and 1.2. Now, this question here, the customer presents, or the patient presents with the lithium 1.4. What do I do? Then you ask yourself, is that a symptom? If there is no symptoms, you continue the medication, but you monitor for lithium toxicity and you repeat lithium levels. So you are monitoring the patient. Yes, there is symptoms. The patient comes with back pain. Let's say if that is the case. Even if the levels is less than 1.3 or 1.3 or 1.4, then you have a symptomatic patient. So you stop the lithium immediately and you obtain labs. Okay? So to answer the question, doesn't matter if it's 1.4 or 1. Oops, 1.3. 1.4. It doesn't matter. It's not that high yield. What is important is that we recognize it is above 1.2. Now we recognize if there is symptoms involved. If there is symptoms involved, we stop the medication. If there is no symptoms involved, we continue the medication. Why do I care about 1.6, 1.2? It's called narrow therapeutic window. If it's narrow, I cannot raise it very fast because if I do, it could be dangerous to the patient. And that lies an answer to another question. So what do you care about? If the patient presents with lithium, with psychosis or not psychosis, manic. Could be manic with psychosis, but manic, it is the prompt. Which of the following medications would you prescribe immediately? We know lithium is the best medication for manic, right? It is the most recommended, but it's not the one that you start immediately. You start a antipsychotic like olanzapine, Seroquel, great one, because you want to bring the patient down first and then carefully start lithium. You do not want to give a bottle of lithium and tell the patient, I'll see you next week for your next appointment, right? Makes sense. But it's tricky because the question says the patient comes with manic event. And you think, okay, lithium is the choice, right? It's most likely the patient needs to be admitted, start with a antipsychotic, bring patient back to reality, and then start lithium. Okay? So again, 1.3, 1.4 is a dilemma here that we always say we need to monitor early toxicity level. No toxicity level, no side effects, not toxicity, side effects, continue the lithium. Has side effects, stop the medication. Now, if it comes to 1.5, we stop the medication immediately, regardless of symptoms or not. Now, here, number 39. So the patient has performance anxiety. Okay? But poor guy, he cannot breathe well. He's taking albuterol. What medication would I prescribe? If you say propanolol, would be very mad. Okay? SSRI is the answer. Why? Because he's an asthmatic. And propanolol will squeeze the hell of your lungs. It will cause bronchoconstriction. So do not prescribe propanolol for someone with performance anxiety if they are taking an inhaler, if they are asthmatic. Okay? Very high yield. So what do? SSRIs. Okay, that is 0.39. So high yield. Okay? All right. Is the safest and most effective maintenance treatment for performance anxiety in a patient with asthma. If they didn't have asthma, then propanolol would be likely your answer. So you're looking two possible questions in one. Do they have asthma or not in relation to performance anxiety? If they have asthma, SSRIs it is. I mean, albuterol and asthma, SSRIs it is. If they don't, propranolol would be the answer. All right. So what do we say about interferon? Actually, we didn't because we're gonna cover it now. Interferon, and the patient's taking Wellbutrin and Lexapro for uh, depression. What does interferon will do to the levels? Now I gotta take that back. What will interferon do to someone that is depressed? It will bring them down. This is not an inducer or inhibitor question. It is one of the questions that I love the most, and most people get it wrong, whether the medication falls under the medication that causes mania or falls under the medication that causes depression. Interferon is high yield for medication that causes depression, right? So what is your action? Is most likely what they will ask you is to increase Lexapro. Okay, so interferon is not an inducer, specifically if we talked about metabolites, right? For metabolism, it's not what it is the question about, but it will do the same act. Here we are looking at how we know that interferon, it doesn't necessarily break down the other levels of Lexapro, but it does cause asthma, right? I mean, I'm sorry, it does cause depression. So sorry, does cause depression. Okay, caused by interferon therapy. Okay, so this is a high yield question for depression. You guys need to remember that question. Okay, number 41. We got 15 more minutes for a break. Okay, so the patient's on Accutane. If she is a female, immediately you need birth control. If you see Accutane, think of some type of birth control. Okay, immediately. Now, Accutane, it is one of the medications that are probably the number one, I would say, that causes most depression. Okay, so oftentimes, at least every 2 weeks, I get a call or a text message saying, "Hey, your patient Marcos, I just want to let you know that I put him on Accutane." Why would the provider call me or text me for this? Because Accutane is high yield for causing depression. So what is your action? Is to increase the medications that likely would help the patient to bring depression to normal levels. Okay? It is well known to worsen or cause depression. Again, what if increasing Wellbutrin or the other medication is not there? Then look for collaborate with the PCM to decrease the medication. Most likely will be there because it's something that you can do immediately. Now, in real life, we probably would do both. We'd have a conversation and so forth. So, Accutane, think of birth defect and think of depression. Okay? So, what you need to do is increase your antidepressant dose to stabilize the symptoms. Okay? So, we are hitting the same points many times. So, why would I care? Depression, right? Birth defects, severe. It's considered severe, very severe, that the patient needs to sign a contract saying they understand the information. Okay, So now it comes down to the points that I've been trying to bring this whole time. Sometimes medications are not inducers or inhibitors, but they are the ones that cause depression or mania. So now let's review what we talked about in module 1. Celled, usually it's 4 celled, right? 4 celled. So it's the 4 S's here that I am concerned. Number 1, syphilis. Number 2, that we see a lot on our test, SAMe. Number 3, steroids. The test will never say steroids. What they'll say, dexamethasone, Flonase, X, Y, and Z. Doesn't matter, right? It will never say steroids. Okay, any corticosteroids can cause mania or depression. St. John Wort and ginger. Okay, so the 4 S's, the medication that can cause mania is syphilis, SAMe, steroids, and St. John Wort. Okay, so we got the 4 S's. How about the A? Antidepressant. Okay, how about the I? We got isoniazid. Okay, then for cell the LE, we have levothyroxine. So this week I got an interesting question. Someone called me and says, email me and said, Dr. Lopez, I don't understand why the answer is now levothyroxine. I was like, wow, I'm actually impressed. You really remembers. Now, in between antidepressants or levothyroxines for medication that can cause mania, antidepressant is more high yield in real life as well. Okay, so that question was a bit tricky and really, really required a higher level of thinking because she was not wrong at all, right? She saw levothyroxine, she went back to this and said, 4 cell, I got it, but may have missed the antidepressant. Okay, so antidepressants, you do not, can cause mania for some people. There are misdiagnosed or poorly controlled hypomania, or simply the provider did not do a good assessment. That is why when someone comes to you with depressed symptoms and has all the signs and symptoms of major depression, you do not call it major depressive disorder until you rule out this is not a bipolar in depressed mood, right? So you got to make sure, because if it's your first time talking to this patient, has never taken medication, super depressed for the past 3 weeks, and you, oh, major depressive disorder, here, take your Zoloft. 3 weeks later, the patient's out and about doing things that they never did before. You just have thrown the patient into a manic episode. Okay, so antidepressants. So from now on, you have to memorize not only the inducers or inhibitors, usually one or the other. You don't have to do both if you don't want to. Recommended, yes. Would I do it myself? No. I would pick just one. Be honest here, okay? Now, I would definitely memorize 4 cell method, okay? I would definitely memorize this, because now, if it's questions 160 and I'm tired and I see levothyroxine, I can go in my dumping sheet and say 4 cell, LE. That is levothyroxine. So that is the cause of why patient is manic. Now, the questions will most likely make it more difficult by saying that levothyroxine is an inducer of X, Y, and Z medication, which most likely is incorrect. The reason why levothyroxine is causing mania is because it is well known to cause mania. So this medication overshoots TSH thyroid hormones, causing hyperthyroid state, which is similar to mania. Okay. Now the last one that causes mania is our good friend of anti-abuse, right? Or disulfiram. It can cause mania, right? It can also cause neurotube defect. Okay. So if you see someone on anti-abuse, think of one of those that could potentially cause mania because it falls into false-celled method or acronym. Please memorize that. Please put that in your dumping sheet. Now, since we talked about the medication that can cause mania, we have to talk about medication that can cause depression, and they are not inducers or inhibitors. So what is that? ASAP, Bs, or ASAP, AB, should be AB here, missing an A, Bs. Okay, so what's the ASAP here? So ASAP is antivirals, okay? So all antivirals really could cause depression. The S is important, right? The S is for steroids. So steroids can cause both mania and depression. The A is for IQ10. So we talked about this a lot, right? IQ10 can cause depression. P, progesterone, right? So progesterone may worsen depression. Very high U2, okay? Birth control, okay? Now, ASAP, we got the ASAP, AB, antineoplastic meds. So this brings another point that is high U. So patient is on any antineoplastic meds, right? Cancer meds. So now we have 2 points. Point number 1, it can cause depression. Point number 2, they are very likely depressed going through all this anyways. So what medication would you suggest? Write it down. Lexapro is the least drug-to-drug interaction. Another email that I got this week was, Dr. Lopez, you have 2 notes. Which one are the most correct? Is it Lexapro or is it sertraline? Well, if the question is about a patient with lots of medication, pick Lexapro. If the question is about which medication would you prescribe for someone with least cardiac involvement, sertraline would be the answer. But in fact, any SSRIs, not any, take Prozac out of the count, would be least drug-to-drug interaction. But number 1, Lexapro. Number 2, sertraline. Please write that down. All right, back to ASAP, AB, B. So what is the Bs? BIS, beta blockers, right? Remember propranolol, never with asthmatic patient, and it also causes depression. And benzodiazepines, right? AB is an antineoplastic, beta blockers, benzodiazepine, interferon, super high use. Okay, when we covered this earlier. And statins. So we now know that if we memorize ASAP, AB, Bs, we have a very strong acronym for medications that can cause depression. Okay? ASAP, antivirals medication can cause depression. Steroids, IQ10, progesterone. ABs, antineoplastic, we got to remember Lexapro, the least drug-to-drug interaction, and beta blocker. Bs, BIS, benzodiazepine, interferon, and statin. All right, so we hit it 12:30 Eastern Standard Time. I know there are lots of questions, and I would and will absolutely answer all of them. But for right now, what I need you guys to do is stretch. Stretch, go get some chocolate, some coffee, prepare your food, and come back exactly at 1 p.m. So it's half an hour from now, and then we'll jump right into our training again. But I will answer all your questions today, not tomorrow, today. Just write it down, your question number, so I can answer them. It's very important to me that I answer your questions. Very important.